about neuroprotection, we have to think, as you've all just brought up, do we know who we want to treat? And are the current strategies for selection of these newborns really appropriate for neuroprotection therapy? We have to take into account the potential mechanisms of the brain and repair, and Colin thinks that we should get in there at 1 hour and cool the babies, but yet there are other people who feel that maybe we can wait 12 hours and we haven't lost anything. And there's a current NICHD trial ongoing right now to address that question. And we really have to think about whether we can really repair neonatal brain injury, not just protect or prevent. And I'm going to talk a little bit about new approaches for the development of effective interventions. And I think the best way to do all this is to really manipulate what we know from preclinical studies, which are to think up a scientific rationale for combination therapies, which includes hypothermia and a variety of different drugs that target the spectrum. So in terms of selecting neonates, you just brought up the question of biomarkers. Could we use neuroimaging as a biomarker or after the cooling as a predictor? And I'm going to show you some data from the meta-analysis done on the 3 earlier trials. The clinical predictors that we've used, and you've heard just mentioned, take into account many of the processes that are occurring in these babies, but the key factor is the clinical examination, because everyone knows that acidotic babies don't all become encephalopathic and don't all need cooling therapy. So really coming up with an encephalopathy score, and I was happy to hear that you used something different than Sarnat, George, when we read your article. So if we look at MR biomarkers, there were, in this particular study done by Nikki Robertson, they did an analysis. They reviewed 32 studies. Most of the conventional MR data, when they pooled this data, they found a sensitivity of 91%, which is great, but a specificity of 51%. Part of the problem is that these scans were done over a long period of time, as early as day 1 and as late as day 30 after birth. Late MRI had higher sensitivity, lower specificity than earlier. And the best predictor, or possibly the best biomarker, is spectroscopy. And so if you look at the deep gray nuclei that Eugenio told us was such a predictor of poor outcome, if there were elevations in lactate over a normalized 10AA, then you raise the specificity to 95%. So I think, yes, there is a biomarker, but is it feasible to do MR spectroscopy as you're trying to resuscitate a baby and get that baby cooled? Probably not so helpful. Diffusion characteristics and the Mary Rutherford's description of the loss of signal in the internal capsule were not as discriminatory as the spectroscopy. So when we're thinking about whether we want to treat babies, it's really all about timing, and I keep trying to impress upon you about this window of opportunity. And it's also about the question we're trying to answer. What do you want to use the information for? Are we trying to predict outcome for families or withdraw support? So then you need specificity. And if we're trying to design and utilize this information for clinical trials, then you need sensitivity. I showed you this series of MRIs yesterday to impress upon you that this patient with a middle cerebral artery infarction had evolution of that injury that occurred over 7 days, at least by MRI scan. So hypothermia may be the great way to start, but it certainly shouldn't be the end of our attempts to intervene in what we talked about yesterday, these potential mechanisms. Maybe hypothermia is working here, but it's certainly not going to work anywhere here, so we have to continue to think about these processes. So many people have done this preclinically, and oxidative stress is really starting it all. We know there's oxidative stress. We know that MR spectroscopy can pick this oxidative stress up in the lactate peak. We know that that lactate peak stays elevated. So how can we do something about this? And one of the important attempts to manipulate oxidative stress has not been so productive. And I heard from one of our colleagues yesterday that she has a neuropediatrician who keeps coming to her when she has encephalopathic babies, and he keeps telling her, give the baby allopurinol, give the baby coenzyme Q, save the mitochondria. But when you look at the data, even though there was proven efficacy in rodent models that mimicked this injury, there was no improvement in short or long-term outcome after what we've considered to be birth asphyxia. And this is data out of Utrecht, and Benders published this in 2006. However, there seem to be short-term benefits in babies who are undergoing cardiac surgery when the drug is given before the surgery, especially for the hypoplast. And Clancy published this a decade ago. So maybe we have to think about when the drug's given. Maybe if the drug is given too late into the reperfusion injury, then we're past the oxidative stress, the big burst of oxidative stress, and maybe that's why it's not so efficacious. But there are many other antioxidant strategies, and melatonin has recently taken front and center stage, and I'm going to talk about that in a minute. But as I mentioned yesterday, even though drugs that mimic superoxide dismutase have been used in adult stroke and cardiac arrest studies, that drug would be very harmful to the newborn brain that cannot accommodate the accumulation of hydrogen peroxide that would occur if we gave a push to that pathway. Lipid peroxidation inhibitors like caffeic acid and the lazeroids, ginkgo biloba, may be potential drugs, but none in trial. Free radical reducers. Look what's in that mix, erythropoietin. This is a cytokine growth factor that has protein effects on the central nervous system and may be impacting the brain early as well as late. And I'm going to show you more data about that later. NOS inhibitors have been a bit of a double-edged sword because of where they inhibit. If you inhibit endothelial NOS, you may decrease blood flow. So you want to use a very selective inhibitor, but it should be given only for a very short period of time. Minocycline, which is probably not that safe for newborns because it is a tetracycline derivative, has been shown to mediate inflammation, but the results have been very mixed in preclinical trials in the newborn models. There are other drugs that actually cause hypothermia in the brain, and the cannabinoids are very interesting drugs because they make the brain hypothermic. So I'm going to show you some data for that as well. This is the data on melatonin that really is getting the big push out there. This is data from a P7 stroke model. And even though the melatonin did not decrease the stroke volume here, so here's a ischemic animal with vehicle treatment, 1 dose of melatonin, 2 doses of melatonin, maybe you don't see any effect here at all, and really a big scatter with the data. However, when they looked at microglial activation and in particular myelination patterns, The vehicle-treated animals had decreases in white matter, decreased myelination, and the melatonin-treated animals approached sham animals, which is very nice data and speaks to the issue that we must remember over and over again, that form and function are not equivalent, that you may not preserve form, but you may preserve function. And we're seeing this now over and over again in the preclinical studies where we're not showing this big change in structure. So we're not seeing this absolute recovery of the brain, but we're seeing recovery in function, and we're seeing new cells being born. So keep that in mind, that behavior, when you're reading papers like this, think about the function and not just the structure. And I think that's why so many of these stroke studies failed in the adult studies, over 1,000 studies with no good results, because they looked too early, they stopped the treatment too early, and they didn't evaluate function. So when we think about repairing or preventing neonatal brain injury, we can think about protecting, but you can only protect when you know it's going to happen, right? So if you know that baby's going to undergo cardiac surgery, then perhaps you can think of something to give the baby beforehand. But most of the time, we don't know that this baby is going to be affected unless there's a sentinel event, and potentially we could get in there ahead of time. And I'll talk about Xenon as a potential therapy for the mothers that could protect the fetus. We focused all our efforts on salvaging neurons, and that's how hypothermia came about, and a lot of the targeted pharmacotherapies, because we're thinking about trying to save the cells. But maybe we shouldn't be saving dying cells because they're going to become non-functional. You heard yesterday from Dr. Chilio that if you cause insults in terms of seizures in the developing nervous system, you may not lose so many of those neurons, but what happens to those cells? They become dysfunctional, they sprout, they form aberrant connections. We don't want that. So maybe salvage is not always the best thing. And maybe we need to focus on actual repair, get outside the time period of the immediate insult if we can. So I just wanted to mention that there is a melatonin observational study going on in France at the Hôpital Robert Dupré, and it'll be listed on clinicaltrials.gov for your reading, so it'll be in your handouts, the citation. And it's melatonin levels in preterm and term newborn infants. And the goal of this study is to examine how melatonin changes in the normal preterm baby compared to term newborns. And the hypothesis is that infants born before 28 weeks gestation, they will have melatonin deficiency compared to newborns at term. And maybe if we correct the melatonin deficiency, we may preserve brain function. So this remains to be seen, but it's an interesting concept, especially with the melatonin preclinical studies. So I just mentioned targeting the injury response, but the one thing I didn't mention is that we shouldn't only think about helping neurons, right? Because endothelial cells are important, microglial cells are important, and especially oligodendrocytes are important for preserving white matter. So we have to think about preserving or repairing the whole neurovascular niche. So if we think about salvaging neurons, there have been many therapies trying to alter the cell death cascade by altering apoptosis, and many studies altering inflammation to affect cytokines or microglial activation. And again, this is the pattern where here, inflammation here at this stage is probably detrimental to the brain, leading to cell death. But when we get out later here, that inflammation might actually be reparative. And so we have to think about when these processes are occurring. So if we think about changing metabolism, that makes sense for what hypothermia is doing, and maybe we need to slow things down in order to get in there and manipulate other pathways. I talked to you yesterday about blocking receptor-mediated activity, the excitotoxicity, the glutamate receptor antagonist, and showed you that if you just give a glutamate antagonist to a healthy newborn animal, you can create apoptosis. So we have to be careful about how and when we blockade. I think the real lessons about protecting the brain come from the concept of preconditioning, and you'll hear more about this, I think, in later lectures on the lung. Preconditioning is giving a sublethal stress before the animal, because this has all been done in animals, receives the big severe insult. So a long time ago now, almost 2 decades ago, Jeff Gaudet showed that if he took baby rats, exposed them to relative hypoxia, 8% hypoxia for 3 hours, he could reduce brain injury when he then later subjected them 24 hours later to a severe hypoxic ischemic insult, the carotid ligation and the global hypoxia. So preconditioning definitely protected these brains. And here's a picture from Marcel Bergeron's study. Here's what the normoxic brain looked like with no hypoxic preconditioning. And here's what the hypoxic preconditioning brain looked like. So if we actually knew how to do this or could find drugs that could mimic this, this would be beneficial. And remember this when I talk about xenon, because xenon may be inducing these mechanisms. And you can see here this big shift towards normal with hypoxic preconditioning. And the reason that in part this occurs is because of hypoxia-inducible factor. And I mentioned this yesterday too. Hypoxia-inducible factor is probably one of the key transcription factors mediating preconditioning. And I told you yesterday about the transcriptional activation of a number of genes that increase energy, decrease cell death, and really improve survival through potential neurogenesis mechanisms and angiogenetic mechanisms as well. And one of the key mediators again, so here's EPO again. EPO, a good free radical scavenger, EPO, potentially a protector in terms of initiating these endogenous responses that will prevent or repair the brain. And we did a number of studies to see if this was at all relevant, and I showed you some of this data yesterday, but this is a slide I wanted to show you because it has some interesting findings on it. The desferoxamine, if you remember yesterday, stabilized HIF, so allowed it to stay up for a longer period of time so that HIF-1 alpha subunit didn't decrease when the animal became normoxic. And early, when HIF is upregulated, it's upregulated in the neurons. And with HIF being upregulated, we see EPO being upregulated in neurons. And I think you can see some yellow stained cells here. So the EPO is being upregulated in neurons early, where it may be helping with oxidative stress. But look what happens at 1 week. This is 1 week after the injury. What's happening here? EPO is still being markedly expressed. There's another wave of EPO production. But this time, EPO is in astrocytes, labeled by GFAP. And you can see a number of these cells, which tells us that there's something going on with EPO in terms of repair. It's shifting its attitude, if you will, and doing something different at this phase. And so I showed you some of this data yesterday that EPO, if you give doses if you only give one dose, you can see some short-term improvement at 2 weeks and 6 weeks. But look at this yellow bar. This is the yellow bar of a single dose by 3 months. We've lost the effect. But if we give EPO 3 times, and as late as a week after the injury, you can't tell the difference between the brains of animals who had infarcts and the sham animals. And this was seen in multiple brain regions. And more importantly, and I don't have it right here, the function in correlating with these different brain regions was preserved in these triple dose treated animals as well. So we know that neurogenesis occurs after ischemic brain injury to increase newly born cells to go to regions that need them. And in the neonatal brain, we know that some cells can be reborn, but they can't be sustained over long periods of time. However, recently, it's been shown that EPO does, when given in multiple doses, can sustain neurogenesis in the damaged areas. And in our animal model, I showed you this too, you can see an increase in neurogenesis and a decrease in astrogliosis with multiple doses of EPO. And here's actually the functional improvement that the triple dosed EPO animals have better balance, use their forepaws just like the sham animals. And that water maze that Dr. Chilio showed you before, they can get to the platform almost as quickly as the shams. And time spent in that quadrant where they're supposed to go, they look pretty much just like the shams. So EPO provides hope. And we know now from 2 studies, one out of Egypt and one from China, that in preliminary studies, although they're very small numbers and some of the studies were unblinded, there seems to be some benefit from hypothermia in human-term infants who are birth asphyxiated. So there are studies ongoing right now funded by the NIH and Thrasher to look at EPO in HIE. So let's get back to hypothermia. This is where we're thinking we might be changing metabolism, and I just wanted to just briefly show you some of the elegant data that came out of a number of different labs to show that hypothermia was much better than normothermia, not just early, 1 week after survival, but as late as 6 weeks after survival. And this is where the 6-hour post came from this data. This was a study with Henrik Hagberg. He was actually the first to show it. And then Mariana Thorsen followed in Mariana had a study in 1996 as well showing these data. Here's data that shows that protection with hypothermia depends on delay to time to treatment. And these are the data from Alistair Gunn that got us to that 6-hour time point that clearly showed that there was a loss of efficacy once we got to 8.5 in this fetal model. So I just wanted to go over the entry criteria again. And this, I was just comparing the CoolCap and the NICHD studies for this particular, to make this point, because I think it's important to show that everybody's using these same criteria, as Colin told us too, but signs of fetal distress, which really relate to this, don't capture this. And abnormal neurological signs, when they're present, it's great, but when it's iffy, this is where the AEG trace helps. And this is what the CoolCap traces. They excluded mild cases because these babies all do well. Severe background depression and seizures generally have a poor outcome. Lena Westes and Linda DeVries showed this 2 decades ago. babies with this kind of pattern. But still, these babies were included, but in a secondary analysis, if they excluded these babies, they showed efficacy. The moderate depressed AEG may be the babies who benefit most greatly from hypothermia, and I think this correlates to Collins' data about the significant association with degree of encephalopathy and hypothermia. If we look at the meta-analysis that was published in the British Medical Journal done by David Edwards before George's study came out, these are events. These events are death or disability, hypothermia and normothermia, the TOBY UK trial, the NICHD US trial, CoolCap multinational trial. They all look pretty much the same with reduction of death or severe disability, death or severe, favoring hypothermia, which was the reason why ICE had to terminate. And these are the events that are survival with normal neurological outcome. These were the most important results, I think, because here, for every single one of these three trials, we see a benefit, survival without severe disability. I'm sorry, survival with normal neurological outcome, which says right there that there was not a shift. Our major concern with the hypothermia when we went into this was that there was going to be a shift toward major disability, that we would recover babies with hypothermia who should have died and instead live with severe disability. We did not see that. We did not see an increase in CP. And although we didn't show this beautiful correlation with CP being decreased, if you put all of the numbers together, it looks great. But each study didn't have enough numbers to show benefit for prevention or amelioration of CP. And because I want to give George proper airtime, and because his study actually showed something quite important. So this is the Neo-Neuro Network randomized clinical trial. And this was reported last October, I think, in pediatrics. And in this trial, hypothermia with morphine as co-treatment had a statistically significant neuroprotective effect, even for neonates with evidence of severe HIE and greater efficacy characterized by a lower odds ratio than in previously published trial. How many people prevent shivering with morphine? How many people use morphine for, I just want to see hands. And other opioids, fentanyl? Okay, so overall, we may be doing the right thing inadvertently. Marianna Thorson pushed very hard for these babies to get treated to prevent shivering, and I think here George's data strongly suggest this. And now with that recent data that I showed you yesterday about limb post-conditioning, that ischemic post-conditioning possibly being mediated by morphine, gives even more added fuel to the fire of using morphine with hypothermia. So the other interesting thing we've seen when we look at MRI as a predictor of outcome, we're seeing a shift in these these very severe basal ganglia lesions. And this is actually old data by Mri Rutherford, which showed very nicely that there was a shift, whether it was selective head cooling or whole body cooling, didn't matter. Basal ganglia, thalamic lesions decreased. And this is hard to read, but it's in your handout. And this is the grades of cerebral lesions seen on MRI in cooled and non-cooled infants in the TOBY trial published by Mri Rutherford last fall. And what all of these data show you is that there is diminution of injury, especially in the basal ganglia in the cooled babies. And when you look at MRI abnormalities and outcome up to 18 months of age in the cooled babies, the major MRI eye abnormalities were defined as moderate or severe basal ganglia or thalamic lesions, severe white matter lesions, or abnormal posterior limb, as she described previously. And severe disability was defined as at least a low MDI or Bailey score, or a score of 3 to 5 on the gross motor function score, or bilateral cortical visual impairment. And major MRI abnormalities defined as she did, and severe disability defined as she showed, were definitely shifted away in the cooled babies. So very heartening data in their secondary analyses. My computer doesn't want to move. I don't know why I'm stuck here. Here, let's see. There, I'll just click that way. So we also looked at our data, UCSF. We've cooled now about 75 babies, but this is data looking at 35 hypothermic babies. We no longer randomize. Every baby who qualifies gets cooled. So the control babies that are shown on this graph are actually historical, if you will. So these were pre-cooling. We started cooling in 2008. And basically what we showed was that there was a shift in the cooled babies with, again, very similar to Mary Rutherford's, that the extent of injury to the basal ganglia thalamic region was diminished in the, with the more severe injury being shifted, so that cool babies had less basal ganglia thalamic, and that the predominant pattern of injury was normal in our cool babies. They still had similar watershed lesions, and the basal ganglia lesions were markedly shifted in these very limited numbers of babies. It's our feeling that the basal ganglia thalamic lesions really are hallmarks of sentinel events occurring in the babies, and that the watershed injury really marks injury that is probably prior to birth with repeated bouts of hypoxia ischemia, most commonly associated with a maternal history of decreased fetal movements. And so there's another paper in JPEDS where we talk about events and related to pattern of injury, which I won't talk about here, but I can discuss with you. So let's mention a few things about the determinants of outcome, and this is from the CoolCap trial again. Things we all know now, encephalopathy grade was very important in determining outcome. AEG seizures actually were important. Birth weight was important. And I actually noticed, Colin, in your study, your control babies were bigger for some reason. I don't know if that was statistically significantly different, but they were bigger. And that also is an indicator or a potential confounder. Gender didn't matter, and APGAR score didn't matter, but temperature did. And this is why I asked this question and why George and I turned to each other quickly and said, what about the hyperthermic babies? So at least in the CoolCap trial, pyrexia was observed in many of the non-cooled infants, and there was a significant odds ratio of 2 in these babies when tested individually. And then when tested with birth weight, it became non-significant. So it's unclear what that interaction is really about. But I think we could at least be aware with the big babies, and also certainly be aware that pyrexia is a modifiable risk factor for brain injury. So one thing we also know, and I think this is important too, because many people got disheartened when they did cooling because they would warm the baby and the baby looked just as crappy as the baby looked when the baby started being cooled. But what we found out, at least in the CoolCap study, that the cooling did not affect the evolution of that encephalopathy, that it wasn't whether the baby woke up encephalopathic or not, that the cooling still had a beneficial effect. And babies who were encephalopathic still on day 4 still had better outcomes than the babies who weren't cooled. So don't be concerned if your babies still look encephalopathic when you warm them. So let's talk briefly about manipulating hypothermia with mechanisms that can perhaps synergize with inhibiting some of these pathways and stimulating this pathway here. So probably one of the earliest studies was by Faye Silverstein, where she nicely showed in a rodent model, again, this same Vannucci model where you tie off the carotid and put the animal in a hypoxic chamber, mimicking at P7, which mimics term. So when she did the study, single therapy with hypothermia alone or with AMPA blockade did not really provide any long-lasting protection. But when she put them together, she saw a beneficial effect on brain structure. It wasn't massively robust here, but it happened. But more important, it preserved brain functionality. So on a number of behavior tests, and I think mostly for this study, they did the four-paw response when you scratch the whiskers. And that showed very nicely benefit when you put those two drugs together. This data I find very exciting. This is Xenon and Hypothermia. Mariana Thoresen got this ball rolling with piglets and rats. And Marvin Mays has also done a number of studies to look at the mechanism of this effect. Xenon coupled with hypothermia. Actually, there's a lot of data on these slides, but the important thing to note is that Xenon with hypothermia improves both function and structure as late as 10 weeks after the injury. So if I can show you here, there doesn't seem, although there is a bit of a difference between males and females, the gender effect wasn't significant here. And if you look at the different parameters of Xenon with hypothermia, all the regions showed benefit, which was really exciting news because Xenon, although an expensive noble gas, could actually be administered to the baby safely. And I think Mariana is doing those studies right now. But it also can be given to the mother. So if we really do have a baby in fetal distress, potentially we could think about designing a study where the Xenon is administered as the anesthetic for the mother for the C-section. So this is all a possibility and things I think you'll be hearing about in the future. And what Marvin Mays has shown with Xenon is that Xenon actually upregulates HIF and these preconditioning responses, as well as inhibit the NMDA receptors safely without causing neuronal cell loss. So it's got lots of important mechanisms that underlie its potential benefit. Doe Jenkins has shown that N-Acetylcysteine in combination with hypothermia actually showed nice protection, and the animals given both drugs for, I think she did systemic hypothermia to 30 degrees for 2 hours right after the ischemic insult, and she gave the N-acetylcysteine not once, but all the way till sacrifice. So it was continuous treatment over a long period of time that showed this beneficial effect. And here's the drug that I think is totally cool because it cools the brain. So the cannabinoids, you know, there's a lot of emotion associated with cannabinoids because of potential abuse characteristics, but they are This is a beautiful endogenous compound. We have cannabinoid receptors on neurons. We have other receptors on glia and immune cells. The cannabinoids reduce the body temperature, and in a number of animal studies and in the dish, it has been shown to they can reduce excitotoxicity by blocking glutamate release, and especially AMPA-mediated toxicity. Cannabinoids also decrease NO production in the brain, and they decrease cytokine release, especially TNF-alpha. And there have been some recent studies to show that the cannabinoids are neuroproliferative, with high concentrations seen in the subventricular zone, that zone I showed you yesterday, lining the ventricles of the brain, where all of those stem cells come from. More recently, Faye Silverstein has gone on to look at hypothermia and phenobarbital. How many people use phenobarbital as drug of first choice for seizures in the hypothermic seizing babies? Okay, so again, with phenobarbital and morphine, we may be already doing a pretty good job for our babies, and hopefully we'll see some benefit from that. So she showed in her study that giving phenobarbital, and this actually was just a single dose, so pretty encouraging. So even with one single dose, there was a synergistic effect of phenobarbital with hypothermia that was above hypothermia alone and above phenobarbital alone in all regions. I wanted to mention a little bit about neural stem cell therapy, because this could be a whole 2-hour talk, if you will, but I think that we are now getting very close to seeing some very good results in the neonates, and this is very nice data just published in Stroke in the fall. We can see engraftment of these cells here using this very nice optical imaging technique. And importantly, what these folks showed was, even though there wasn't massive structural change, again, improvement in function without massive engraftment of the cells. And I think you're going to hear more from Dr. Thibault about how these cells are really little pharmacological supply houses. And I have 2 slides here, not because I want to go through and read these awful slides, but because I want you to see, based on this very nice review article in Stem Cells in Development, how many people are thinking about this and how many studies are being done in preclinical models. So if you want to go back and pull out any of the individual papers, you can go back to the review article in Stem Cells in Development. But you can see there are numerous studies. So it's not just stem cells, it's more, we should more call this cell-based therapy, because some people are using mesenchymal stem cells, some people are using umbilical cord blood, and others are using actual neural stem cells. And most of these studies, you will see over and over again, improved motor outcome, improved sensory motor deficit, but you're not going to see a lot of improvement in structure. So I think moving away from using purely structural analysis will move us forward in finding the right therapies. I just wanted to mention briefly that this study has just been completed. I think it says here, this is an older snapshot that I took, but I just wanted to show you that the cord blood for neonatal hypoxic ischemic encephalopathy is being done out of Duke, and it is now closed. I think they finished their enrollment as of January. It's a pilot study to test feasibility of collection, preparation, and infusion of a baby's own umbilical cord blood in the first 14 days after birth. So we don't expect to see a lot of data from this except for safety data. And there is a cord blood symposium that is going to be held soon in the US, and hopefully we'll get a little bit more information from these studies that are ongoing. So I hope I've shown you through these investigations that there are many ways that we can achieve neuroprotection. And I think, and I hope that you believe as well, that we have to target multiple mechanisms in order to achieve absolute repair. And I think the preclinical evidence for hypothermia with adjunctive therapies is really pointing us in the right direction. And hopefully we will have more capability soon for our babies. Thank you for your attention. Any questions, comments? Yeah.
Excuse me, do you talk about the use of phenobarbital? And I don't understand if you mean as a neuroprotective achievement or a single dose for seizure.
The preclinical study I showed you was just a single dose given to mimic the situation often occurring in our term babies where they come in and we've heard that they've had a clinical seizure and they've received a single dose of phenobarbital, maybe from the referring hospital, or we see a clinical seizure and give phenobarbital, but there are no subsequent seizures. Even in that setting, preclinically, the phenobarbital coupled with hypothermia seemed to protect.
Okay.
Yeah.
Another question. When you talk about melatonin, what is, in your opinion, the best hours to give melatonin, since babies have a circadian, do not have a circadian rhythms, so it's difficult to
Yeah, I will not answer that because I don't know the answer, and also because nobody knows the answer.
Yes.
And I think that's the benefit of the French study that is starting to enroll babies, that we will learn from their data when the peaks and troughs occur, how much the levels are dependent on gestational age, and hopefully they'll next move to asphyxiated babies to see what happens to melatonin levels with insults.
Okay.
Yeah.
The Xenon, it looks interesting, but is it ever going to be useful, practical?
Because of the cost?
Because of the cost, and you need special equipment to scavenge it, and special anaesthetists to run that equipment.
Well, our anesthetists do not think you need to be special to administer, because they all are very special and can handle any gas. But you're right about the equipment, and you need special equipment. But Marianne Thorson has developed a system to scavenge, and she's reduced the cost by 50-fold using this equipment. And I imagine some company is going to end up marketing this to their benefit, but the net effect would be to reduce cost.
I want to ask you about phenobarbital. There were 3 publications where they used phenobarbital as a single treatment, not combined with hypothermia, and there was no real evidence. But now with combination, combining it with hypothermia, it seems to be really making a difference. Is there any explanation why phenobarbital as a single treatment after delivery was very popular by many because it's available, but the evidence for the effect was very low? But now with combination, combining it with hypothermia, it seems. Is there any sort of explanation for that?
No, I don't think we've really been able to understand this mechanistically. The phenobarbital, as you know, Chris Ikenemoto also showed, in addition to the NMDA receptors, that phenobarbital in a normal rodent brain could cause cell death. So people were very worried about phenobarbital causing apoptosis, even in limited situations. But it turns out, again, that maybe it's just accelerating normal programmed cell death and not really affecting eventual outcome. Alone, it doesn't seem to do anything, and I don't know why in the early studies there weren't any good effects, but it seems, I think phase data is pretty robust, that even with a single dose that she was seeing marked improvement both functionally and structurally in these animals. But in terms of mechanisms, I really would just be guessing.
I hope the audience allows me one more question about dextromethorphan.
Mhm.
We have shown in animal experiments that it is very effective in reducing the injury effect. Dextromethorphan is a stuff which is an
Cough syrup.
anticonvulsant and it's also in cough syrup and is used. Have you any comment on that?
No, I think there are very good preclinical studies, especially in adult models, that show benefits with dextromethorphan. And yeah, it's, again, it was another one of the drugs on Chris's list causing apoptosis, but we don't really know what. Morphine, yeah, that's a good point. Good point. Yeah.
You have shown yesterday, and you've already suggested today, that maybe the window of opportunities may be longer, more than a few days. Why don't we do trials, or why aren't there ideas of making the hypothermia going 1 week? Because you said yesterday that some of this inflammation and gliosis processes might take longer.
Yeah. Well, as you know, clinical trials are very hard to do and very costly. There is an NICHD that is looking at delayed hypothermia for longer periods of time, but I think it's not as long as a week. It may be that we need to think of other things to add to the hypothermia. I think the important information that will come from that study is that we don't have this critical 6-hour window, which sometimes eliminates babies from being enrolled. And I just remember dextromethorphan does gate the NMDA receptor as well as work on opioids. So I don't know if there would be added efficacy. And we'll see from this trial, it's going to take a few years before we have that information.
Hypothermia also for babies who are not as fixated, but we are going some kind of hypoxic event due to other reason. We are working in South Germany, and many colleagues. First of all, we use hypothermia for premature babies, babies who are under the 2 kilo that were initially in the trials were, and also from the people who are working with cardiac patients, that they were going some kind of hypoxic event. So they also use hypothermia for these babies. And we also had some babies who were found hypoxic in the nursery without an asphyxia history, and they were also doing hypothermia. Do you have any experience?
We do not use hypothermia for any baby less than 36 weeks gestational age. And a criteria in our unit for hypothermia is encephalopathy. So even if they have the other clinical biomarkers for HIE, they will not be enrolled unless they're encephalopathic. Hypothermia is used for cardiac surgery. There are trials, as I spoke about yesterday, for children for cardiac arrest, so I imagine we're going to learn more. Eventually, people will be studying hypothermia in the preterms, possibly. The problem I have with the preterm is, what event are we modulating? You know, this is a chronic condition, and what is the what are we targeting? Where's the begin point for hypothermia in a preterm? I just don't know the answer to that unless you have a preterm who had a severe, you know, an abruption or something like that. That's much clearer, and those babies deserve study. But I think just because you're born prematurely doesn't, and you're hypoxic, doesn't mean you should be cooled.
How many people are using hypothermia?
Amazing, huh? Yeah, just, you know, 2 years ago giving this talk, and I was just commenting to somebody else in the audience the other day when I first started giving this talk and giving talks about protecting the brain. Everybody was using head ultrasound, and every time I mentioned MRI, I got sneers and bad looks. But it's just encouraging to see how far we've come and how comfortable we've come with some of the technology for the babies. And it's certainly encouraging that so many people have lost equipoise for hypothermia, because it really is a decent therapy.
Excuse me, what can we do for babies, out of protocol babies? Babies who are referred, who can start active hypothermia after 6 hours because referred too late, or living in a rural hospital where it's more than 2 hours or 3 hours of ambulance trip, and babies who were born with an history of an ischemia with a bad CTG, but have not the criteria. It's the no need to resuscitation after 5 minutes, but they start developing at 2 or 3 hours bad neurological signs, subtle seizures, and with no cord gases or blood on the first hours of life.
Yeah, I think if you can't enroll treat the baby for hypothermia because they don't satisfy the criteria that you've set up in your hospital for a standardized protocol, that at least you can make sure that they don't become pyrexic. I think that's probably one of the single best treatments that we can afford these vulnerable babies. And also, because I'm a believer in the fact that I believe, it's not a fact, I believe that clinical and electrographic seizures damage the brain in any setting, independent of hypoxia ischemia or with hypoxia ischemia. So I would say careful monitoring of the babies with AEG, which is very simple, and quick treatment of status epilepticus and recurrent seizures will also benefit the child, we believe. Colin?
If you're in a small centre and it takes you a while to get in, as we've shown from ours, you can call these babies simply during transport. You can call them at the birth hospital. I mean, that was one of the main things about our study. And just because you don't have some fancy equipment to go in your transport incubator doesn't mean to say you can't cool the babies in a simple fashion.
Right, and I think many people are doing passive cooling. How many people have to transport babies and do passive cooling from their outside hospitals? I think that's a common approach.
But you don't have to do passive cooling. Just take some little cold jelly packs and you can use active cooling. I mean, you can